Dear audience, let me present to you my PhD thesis so far investigating the cardiac complications associated with acute pancreatitis. My name is Veronika Lillik. I'm a third-year internal medicine resident at the Hospital of Székesfehérvár, and I'm a second-year PhD student here at the Center for Translational Medicine. My vision is to decrease the mortality of acute pancreatitis by foregoing the preventable complications, and my mission is to conduct high-quality research assessing the effect of acute pancreatitis on the cardiac status. I have 4 ongoing projects with retrospective, prospective, and meta-analysis methodologies to assess this topic. First, let me start with the meta-analysis and systematic review, assessing bidirectional interaction of the heart and pancreas in acute pancreatitis, which is a systematic inflammatory disorder with rising incidence and high mortality in the severe cases. Organ failure is one of the most important predictors of mortality and severity, and heart is a common organ involved in the cause of death. A recent registry analysis showed that the mortality during the first 90-day period after discharge is almost the same as during hospitalization, and 22.5% of this post-discharge mortality is because of cardiac failure. That's why there's a need to cover the importance of cardiac-related abnormalities in acute pancreatitis. In recent cohort studies, it has been shown that certain cardiac changes on ECG, echocardiography, and laboratory markers are associated with the severe forms of acute pancreatitis. And we divide this disease into 3 severity stages based on the presence and duration of local and systemic complications. Our aim was to investigate the bidirectional association between cardiac changes and acute pancreatitis outcomes. Our clinical question was what cardiac-related abnormalities are associated with worse outcomes in acute pancreatitis. The population was patients with acute pancreatitis. The investigated factors are cardiac-related abnormalities. The outcomes are mortality, severity, and length of hospital stay. We had another framework where the population is the same. Here the investigated factor is the severity categories of acute pancreatitis, and the cardiac abnormalities are the outcomes in this framework. We conducted a systematic search in 3 main databases with the following search key on the slide, and it yielded around 20,000 articles, and in the end we could include 50 of them. I will present my results on forest plots. Here in this first one, you can see that we included 7 cohort observational studies with 1.7 million patients. The investigated factor was the chronic heart failure in the patient history. The outcome is in-hospital mortality. Based on this figure, we can say that patients with chronic heart failure in their history had 3.4 times higher odds for in-hospital mortality during acute pancreatitis. In this next figure, the investigated factor is atrial fibrillation. We included 6 cohort studies with 1.2 million patients. The outcome is also in-hospital mortality. We can say that patients with concurrent atrial fibrillation have 2.7 times higher odds for in-hospital mortality during acute pancreatitis compared to those without atrial fibrillation. This next plot, we included 3 cohort studies with 380 patients. The investigated factor is the severity. So we compared severe and moderately severe acute pancreatitis to mild acute pancreatitis. The outcome parameter is the repolarization on ECG. We can see that patients in the moderate and severe acute pancreatitis group have 2.75 times higher odds for repolarization changes on ECG. And in this next plot, we have the same comparison between the severity groups, and the outcome is the QTc prolongation on ECG. We can see an odds ratio of 2.25, but this analysis was not statistically significant. The strength of our study is that this is the first comprehensive meta-analysis in this project, and we could include in certain analysis high patient numbers. The limitation is coming from the observational nature of the studies, because the time frames and definitions wasn't strictly defined. The conclusion is that patients with atrial fibrillation face a threefold increased odds for in-hospital mortality in acute pancreatitis, and those patients with severe and moderately severe acute pancreatitis are 3 times more likely to develop repolarization changes on ECG. The implication for practice is that cardiology screening, at least regular ECG, is needed in acute pancreatitis patients, and the implication for research is that better conducted longitudinal studies are needed assessing more kinds of cardiac parameters. We have our manuscript under revision at iScience, the Cell Press. My second project is investigating the cardiovascular abnormalities before and during acute pancreatitis. This is the post hoc analysis of the Prospective Hungarian Pancreatic Study Group registry with 4,000 patients. Our clinical question is what pre-existing and newly developed cardiovascular abnormalities are associated with worse outcomes in acute pancreatitis. We have the same framework. The data collection and validation is done. We have full data on 1,312 patients from these 4,203, and I will show you this single center preliminary results from the Semmelweis University Institute for Pancreatic Diseases. So this is the first preliminary result. It shows that newly discovered atrial fibrillation has an odds ratio of 4.4 for in-hospital mortality, but this is not a statistically significant result yet. This second figure shows that patients with acute heart failure during hospitalization had 25 times higher odds for in-hospital mortality during acute pancreatitis. Maybe it's not so surprising, but this other figure shows that patients who had acute heart failure during hospitalization have 5 times higher odds for post-discharge mortality within 1 year. This is a statistically significant result. We have some data about ECG. The QTc prolongation on ECG is not yet significantly associated with higher in-hospital or post-discharge mortality with odds ratios of 2.1 and 1.65, but we are expecting more data and we are expecting more significant results in the future. This is the progress of the registry. We need to further extract data from the database. My last project is investigating the pancreatitis-associated cardiac complications during and after acute pancreatitis. This will be the PANCA study, which is a prospective observational multicentric follow-up study for the clinical questions. What are the incidences of cardiac changes during acute pancreatitis? How are they time-dependent during the disease course? What is the association of them with the acute pancreatitis outcomes, and more importantly, which in-hospital cardiac changes are associated with worse post-discharge outcomes. We have the same framework. In the in-hospital model of the study, the primary outcome will be the severity of acute pancreatitis, and during the follow-up study, the post-discharge overall mortality is the primary outcome. The clinical implication of this study could be that cardiology screening is not only needed during hospitalization, but also in the post-discharge patient management to detect these changes early and with interventions prevent mortality. This is the planned flowchart of the study. We would like to take cardiac laboratory markers and the 2-minute ECG every day during the first week. And if we detect any abnormalities on the ECG, we would like to do a 24-hour Holter ECG monitoring. And also, in addition, we will do an echocardiography within the first 24 hours, and after that, every 7 days. This is the progress of this clinical study. We are currently finalizing the manuscript for the protocol. Here you can see the summary of my ongoing project assessing cardiac complications before, during, and after acute pancreatitis. These are my additional activities. I presented our results in various national and international conferences. Let me wrap up my presentation with a quote from Albert Einstein: "Life is like riding a bicycle. To keep your balance, you must keep moving." Thank you.
Thank you very much, Veronika. Well, you thought a lot about the heart and the pancreas, and you involved Holter ECGs in the last trial. I didn't understand. Is that ongoing or is that already done?
No, it's planning.
It's planning. Well, maybe a piece of advice. We have cardiologists in Munich who are very heavily into these wearable devices. And they did a study on volunteers on the Oktoberfest. Volunteers binge drinking versus not binge drinking. And it's a remarkable, I think they got it into the New England Journal of Medicine. The simple trick is if you tack a device on these patients, so they rather than complicated Holter ECGs, you can register so many things. And if you find a sponsor, and with the new artificial intelligence methods of it's a massive data. But think about getting a sponsor for high-end devices for these patients, so you will find a lot of arrhythmias that you don't usually show up in a Holter, and that would be one thing you could do as an interventional perspective a trial for this. But what are our consequences? Do we need to? I mean, AFib, why would these patients die earlier post-discharge? Any idea? Do they get thrombosis in the pancreas? Do they have pulmonary embolisms? Do they have cardiac failure? You have any information on why having these minor abnormalities is so dangerous in the long run?
Yes, thank you for the suggestion, and this is a great question, because this is also my thinking that this is a relatively high prevalence disease, atrial fibrillation, and it is not that higher mortality in the general population. From the meta-analysis, I can't answer this question because they didn't state the reason for mortality. In the registry analysis, I will be able to answer this question partially, because we are collecting the pathology reports of the diseased patients from the registry. So I will have an answer. I also have theories. I also have your theories that maybe it is thromboembolism after and during the SIRS in acute pancreatitis, maybe that can affect the coagulation.
Very good. Questions from my co-investor.
Thank you very much. Nice presentation. I have two questions. One question is about the etiology, because alcohol alone can also cause cardiac things, so it can affect the heart. Do you know whether these cardiac failures were increased in alcoholic etiology, or, for example, in hypertriglyceridemic etiology compared to the biliary etiology? This is one of my questions. The other question is about the comorbidities, because diabetes mellitus or hypertension can cause atherosclerosis, which can also affect the heart. Do you investigate, or do these articles investigate these kind of comorbidities?
Unfortunately, for both of your questions, in the meta-analysis, we don't have data for these parameters, but that's why that we conducted the meta, we are doing the other 2 projects to investigate this more. In the registry and in the protocol, we will make sure to have this data, because in the meta-analysis I couldn't do any analysis on the echocardiography, and alcoholic patients have dilatative cardiomyopathy, which can influence the ejection fraction greatly, and maybe they have acute cardiac failure because of that, and not just because of the pancreatitis. So I'm really interested in the echocardiographic findings of the clinical study to answer this question, and also we are collecting data from the patient history regarding the other cardiac factors. Thank you.
Congratulations. I would like to ask you why you decided to combine moderately severe and severe acute pancreatitis groups in one of your studies, because we do see difference in mortality quite a bit.
Yes, I totally agree. The honest answer is that the papers reported the data this way. So this was the only way we could pull together these articles, but we really plan on, if we do our own analysis, we are planning to do 3 separate categories. Also, I think there's a reason they reported it together, because the severe acute pancreatitis prevalence is lower, and maybe they could only make the mathematical calculations if they pulled it together, but this is just an assumption.
You mentioned regarding your second topic that there is higher incidence of acute heart failure in acute pancreatitis patient. So what's the explanation for that? And do you think that it would change the or therapeutic steps, because the first-line therapy is high volume fluid supplementation?
Yes, I totally see this. With the echocardiography, we will be able to assess the patient's fluid status and also the end-diastolic volume, which will have a great amount of information for this question, whether the volume therapy caused the heart failure or quite the opposite, the hypovolemia caused the heart failure. So this is one part of my question. What can cause acute heart failure in acute pancreatitis is severe. There are severe explanations. The most common one is the SIRS, so the systemic inflammatory response syndrome can affect the heart. Also, there are basic research on the myocardial depressing factor, which comes from the pancreas during acute pancreatitis.
And is there any prognostic factor for the development of acute heart failure?
I don't know about this yet, but maybe from our study we can prepare a prognostic table for this.
Thank you.
Thank you.
Thank you. You mentioned that there is a high time dependency between those outcomes, and how do you plan on your study if it comes to life? The time frame also is a survival analysis, which is usually 5 years. How do you plan to follow up the patients that long with all the parameters you want to assess?
Yes, probably we won't be able to do this survival analysis for 5 years. Our feasible plan is to do 3 months, 6 months, and 12 months follow-up visits. We are mainly focusing on the changes in cardiac parameters, because this is a really new field, and maybe we will have answers besides mortality is a higher outcome. So if we have significant data, which is not expected, because we should wait for a longer period of time, but maybe with the secondary outcomes we can have a picture and plan better studies in the future.
Thank you.
We're all done. Thank you very much, Veronika.
Thank you.